So during the cancer, there is many substance or materials you can say which is released and you can use as a marker for the diagnosis. Even during the treatment also you can use. So what do we mean by tumor marker? It is a molecules or substance that is present in the higher amount than the usual concentration that you can see in the tissue, serum, urine, and other body fluids in the patient having the cancer. So these molecules can be present in the body fluids, even the urine, in the blood, and the tissue. So all of this can be used to detect the molecules which is released during the cancer in that particular patient. So you can use as a sample, you can say this blood you can use the urine sample, you can use the body fluid as a sample, and even the tissue. Even the tissue you can use as a sample for these markers in the patient having the cancer. So during the cancer, these markers will be released. Okay. So it is present in all this, even the cell membrane, cytoplasm, and nucleus of the cell as a receptors. Some of the receptors also act as a tumor marker. So in the blood, there is a two components. If you have remember your hematology class, two component, blood cell and the plasma. Blood cells contain RBC, WBC, and platelets, and plasma is the water part. Okay, plasma what contains the plasma proteins. If this blood is collected in the anticoagulant, the vial which contains the anticoagulant, in that if you add the whole blood and if you centrifuge, you'll get the two parts. One is the white part and second one is the red part. So that red part contains the blood cells and the white part is known as the plasma. Between these two, there is one white layer that is known as the buffy coat. Okay, but the serum means you have to collect the whole blood in the plain tube, or you can say the gel tube, and leave it for the half an hour so that it can clot properly. And after the coagulation, after clotting, you can centrifuge it and you'll get again two part on the white part, white liquid part, and second one is the blood which is settled down. Okay, in between, if it is a gel tube, gel will remain between the white fluid and the blood cells. So that white fluid is known as the serum, which does not contain the clotting factors. So clotting factor is deficient in the case of serum, but in the plasma you'll have the clotting factors. So in the biochemistry, mainly you'll use the serum rather than the whole blood. Mainly you'll use the serum. So you have to collect the sample in the plain vial or gel tube. Okay, plain tube or you can say the gel tube, and leave it for half an hour so that it can clot properly. Then you can centrifuge, and what you will get, that will be the serum, which does not contain the clotting factors. Different body fluids can be used. Okay, so what are the criteria for the tumor markers? Not only the tumor markers, any ideal markers. These requirements can fit for the any ideal markers. Okay, not only the tumor, it can be fit for the cardiac markers. So what is the requirements to be a ideal tumor markers? The first point is highly sensitive. That marker should be highly sensitive. That means no false negative results you'll get. No false negative. Highly sensitive means if it contains even in the small amounts, it can detect. That much sensitive. That's why it should be the highly sensitive. Second one, it's a highly specific for that particular disease, for the particular cancer. It should be highly specific. That means no false positive results. No false positive. If it does not contain, means it should give the negative result. Not even look like that type of molecules and shows the positive. Not like that. that what specific it should be, that tumor marker. And tumor marker should reflect the tumor burdens. Okay, the level of that markers should reflect the tumor burden. Okay, the mass which is present in the cancer people, that should be reflected by these markers. If it is a very small growth, the level should be little bit upper. If it is a very too much growth inside the body, the cancer patients, the amount should be that much high. So that will fulfill the criteria for the tumor markers. The first one, highly specific, sensitivity, and the can detect the tumor burden. The level should remain relatively constant and not fluctuate in the patient with a stable disease. If you have done today, it should be constant. Okay, the level should be constant, not fluctuate too much. It should be the constant for the stable disease. If it is a growing, the level can be fluctuate, but the disease is stable, it should be constant. Okay, should be undetectable or low on the patients in compatible remissions. If patient is getting recovered, the level should decrease. If it is completely recovered, the level should not be detected. That tumor marker should not be present, you can say, or it should be very low, either undetectable or it should be very low. Should predict the outcome in patient with the stable disease. You have performed the tumor marker. If you're not getting any outcome, there is no use of that tumor markers. Okay, and the most important part, you can say, cost effective. If the tumor marker is not cost effective, we cannot use it. It should be cheap so that patient can afford it. Just take the example, if tumor marker cost the 10,000 rupees for one test, patient cannot afford that. So there is no use of the tumor marker. That's why it should be cheap. It should be the cost effective so that all the patient can afford that tumor marker and they can be used as a tumor marker. So what the application of these tumor markers? Why you have to use these tumor markers? So this is used for the screening in the general population, for the studies purpose or for research purposes you can use to know the prevalence of particular cancer. So you can use that tumor marker in the general population for the screening of the particular cancers. Different type of cancer, if you want to find out in our population, in the normal populations, you can use that. It can be used for the differential diagnosis in the symptomatic individuals, showing the symptoms of the cancers. For the differential diagnosis, you can use a staging of the cancer. A staging of cancers. For that also you can use the tumor marker. It is initial stage or in the last stage. Prognosis of the cancer. If you have given the treatment, that is recovered or not. The patient is improving or not. Like today you have performed. If it is recovering, the level of tumor marker should be decreased. So for the prognosis of disease also you can use the tumor marker. Evaluation of the success of treatment. As I earlier have discussed, if patient is recovered, the level should be very low or it is not able to detect. Okay. Detection of the reoccurrence of the cancers. Reoccurrence. For that also you can use the tumor markers. Monitoring of the response of the therapy. If you are giving the therapy, that is responding or not. If the dose which you have given, that is working or not. For that also you can use the tumor marker. So in our case, mainly it is used for the diagnosis. Okay, diagnosis and prognosis of the disease. For this purpose, these two purposes, they have used mainly in the developing country. So these are some history of the tumor markers. The scientist known as Ben Jones in 1846, he has identified the protein known as Ben Jones protein, which is present in the urine of the patient which is suffering from the multiple myeloma. Multiple myeloma means cancer of plasma cells. Okay, so in that patient, they have find out in the urine sample the protein, and he has given the name Benson's proteins. Okay, this is the first one, the first marker you can say. In the 1846, by the Benson's, he has find out the marker for the multiple myeloma, that is a Benson's protein, which is present in the urine of the patient suffering from multiple myeloma. 1930s to 1990, acid phosphatase. This is the enzyme which also used as a marker for the prostate cancer. That is in the starting, but not in nowadays they have used. In the starting, during this period, they have used acid phosphatase for the marker of prostate cancers. In 1960s, there is one technique that is known as the radioimmunoassay, RIA, radioimmunoassay, which also help in the discovery of different tumor markers. So this is the method by which you can measure the different tumor markers. So radioisotope have used in the radioimmunoassay. In 1963, alpha fetoprotein, a tumor marker for the SCC, hepatocellular carcinoma. 65 CA for the colon cancers. And in the 75, another techniques had been developed, that is a monoclonal antibody technique. Monoclonal antibody technique has developed, which also help in the finding of different new tumor markers. Okay, if you have the monoclonal antibody against that proteins, you can use it. So this technique have given the discovery of many tumor markers, even like CA125 and all. In 1980, PSA, which is used for the prostate cancers. This prostate cancers, nowadays acid phosphatase is not it. It is used only prostate specific antigen, that is known as the PSA. But later on in the 1780s, this oncogene and tumor suppressor gene also they have used. And later on in the 2001, you can say different many techniques have been developed, microarray, mass spectrophotometry, so which also help in the discovery of the new tumor markers. So discovery of the different methods help in the discovery of the new tumor markers for the different cancer. So you can see some types of the cancer. Enzymes can be used as the cancer, like ALP. Okay, hormones can be used as the cancer tumor markers. Immunoglobulins can be used as the tumor markers. Oncofetal antigens can be used as the tumor markers. Carbohydrate antigens. So these all used as the tumor markers. So based on that, you can say like oncofetal antigens, alpha fetoprotein, CA, carbohydrate antigens, CA125, CA15.5, CA19.9, like this. Other like receptors, estrogen receptors, progesterone receptors, used as the tumor markers. Protein can be used as the tumor markers like beta microglobulin, ferritin. Oncogene products, RAS, MAC, this also can be used as the tumor markers. Tumor suppressor genes like p53, BR, this also can be used as the tumor markers. So based on the nature of that molecules or substance, they have divided the tumor markers based on the nature, either it is the enzyme or it is a proteins or it is a carbohydrate or it is immunoglobulins or it is a hormones or it is the antigens. Based on that, there is a different type of tumor markers. So you can see some common tumor markers which will get in the different laboratory, like alpha fetoprotein, CA, CA19.9, PSA, CA125, beta SCG, okay, PMA. So these all act as a tumor markers like CA15.3, and these are the receptors which also act as a tumor markers. Okay, so there's a common tumor markers, but these are not performed in our setup. In the Manipal, all this is not performed. Okay, like estrogen receptors, progesterone, HER2, BRCA1, 2, and P53. These are the not performed in our setup in the Manipal. But all this is performed in the Manipal, commonly used in the Manipal as a tumor markers. So what are the different assay which is used for the detection of tumor markers? Enzyme assay, like ELISA. ELISA is a enzyme assay. In that, enzyme is labeled. Immunoassay, like KILIA. Okay, KILIA is a new technique which has been developed for the detection of different tumor markers. Before it was the RIA, radioimmunoassay, that uses the radioisotopes, which is very harmful to the workers for the laboratory persons to use the radioisotopes. So which is replaced by the enzyme assay, that is a ELISA. But nowadays this ELISA is also, you can say, the replaced by the immunoassays. Most of the laboratory they use the immunoassay like KILIA. Okay, immunohistochemistry also can be used, receptor assay, mass spectrophotometry, and the microarray. So these are the few techniques. Out of all this, ELISA is also in some of the setup which does not have the immunoassay, but in our setup you have the immunoassay. Okay, and immunohistochemistry, it is used in the histopathology laboratory, but these two which is not present in our setup, but it is also used for the detection of the different tumor markers in the developed country, and even the lab which is highly equipped, advanced laboratory, they have used these other techniques for the detection of the tumor markers. So we'll discuss some of the selected tumor markers which is used for the diagnosis of different cancer. We'll not discuss all, only the few which is very common and also performed in our setup. Alpha fetoprotein, it is known as the AFP. The sample is the blood. The sample which is used is the blood. So take the whole blood as I described before, and in the gel tube or plain tube, leave it for half an hour, centrifuge, you'll get the serum that is used as a sample. It is used for the diagnosis, monitoring the treatment, and determine the recurrence. The normal level is less than 10 nanogram per ml. The normal level of alpha fetoprotein is less than 10 nanogram per ml. It is elevated or seen in the cancer like liver, germ cell cancer of the ovaries and the testes. For this cancer you can use the alpha fetoproteins. But the disadvantage of this tumor marker is also elevated during the pregnancy and in the hepatitis. Okay, not only in above cancer, but also it is elevated in the pregnancy and the hepatitis. So the patient who is the pregnant or suffering from the hepatitis, the level of AFP will be increased. That means it's not the specific. It is also increased in some other diseases, which is not the cancer. Okay. Another is CEA, Carcinogenic Antigens. The sample is again the blood. It is used for the treatment, diagnosis, and determining the recurrence. Normal level in the smoker and non-smokers. They are divided into two groups. Among the non-smoker, it is less than 2.5 nanogram per ml, and in the smoker persons, individuals, it is a less than 5 nanogram per ml. So almost you can say they around double. That means the smoking also affects the level of CEA. So it is done in the case of different cancer like bowel cancers, lung cancer, breast cancer, thyroid, pancreatic, liver, cervix, and the bladder cancers. So large number of cancers causes the increase in the CA, carcinogenic antigens. So CA is increased not only in the single cancer, but many other cancers, the level is increased. That means also it is also not the more specific. Okay. Other than the cancer, it is also increased in some other diseases like hepatitis, COPD, pancreatitis, and in the smoker person, cigarette smokers. It is more chronic smokers, the level will be increased. Not only the this much, more than that should be present. So this is also not the more specific for the cancer. Okay, but it is commonly used as a tumor marker in the normal setting. Okay. Another is the CA 15.3. So the sample is in the blood used for the diagnosis, the staging of the cancer, monitor the treatment, and determine the recurrence. Normal level is the less than 30 U per ml. Okay, unit per ml. It is done in the case of the breast cancers, but also in the lung cancer and the ovarian cancers. So level is increased in the case of breast cancer and lungs and ovarian cancers, but also elevated in the benign breast conditions. Not only the malignant, but benign breast condition also shows the increase in the level of CA 15.3. Another cancer is the CA 19.9. The sample is the blood. The use is same for the diagnosis, staging, monitoring, and determining the recurrence. Normal level is the less than 37 unit per ml, and the level is increased in the case of pancreatic cancers, bowel cancer, and bile duct cancers. So the level is increased in pancreatic cancers. Okay, so you can use for the pancreatic cancers CA 19.9. But not only the pancreatic cancer, it is also increased in the pancreatitis, inflammatory bowel stages. So that means it is also not the more specific for the cancer. But you don't have any option, so you have to use this substance or molecule as the tumor markers. Okay, even though it is increased in the pancreatitis. Okay. Now the next is CA 125, which is commonly done in the case of ovarian cancer. Okay, ovarian cancers, CA 125. Also elevated with the other conditions, you can say, like benign conditions, and it is not recommended for the general screening. For the general screening, it is not recommended. Okay, endometriosis, in that condition also it is increased, and some benign condition also the level of CA 125 is increased. But rather than other tumor marker, this is more specific for the ovarian cancers. For the ovarian, if you are suspecting the ovarian cancer in that individuals, you can go for the CA 125. The normal range is less than 35 unit per ml. 35 unit per ml, and used for the staging of the cancer, monitor the treatment, and determine the recurrence. Even the prognosis, for that you can use the CA 125, and sample is the blood. You can take the whole blood and separate the plasma, not plasma, separate the serum, and you can estimate the CA 125. Other is the prostate specific antigens, which is done for the prostate cancer. It also increases in some other conditions, you can say benign prostatic hypertrophy, and normal range is very less, you can say 0 to 4 nanogram per ml. 0 to 4 nanogram per ml. Help to diagnose, monitor for the prognosis. For the diagnosis, you can use PSA, but nowadays they're using the free PSA rather than the total PSA. Okay, free PSA which is present in our blood, which is measured nowadays, which is more specific for the prostate cancer rather than the total PSA, prostate specific antigen, and sample is the blood. Normal range 0 to 4 nanogram per ml. And the tumor marker that is known as the beta SCG, which is done for the testicular cancer, elevated in the pregnancy and testicular failure. That means this is also not the more specific. Okay, but it is in the testicular cancers, elevated in the pregnancy and testicular failure. But sample here you can use the two, blood sample as well as the urine sample. Both the sample can be used for the beta SCG because it is excreted in the urine, so you can use the urine sample and the blood samples. Because during the pregnancy, the level of beta SCG is too high. That's why to rule out the person is pregnant or not, you use the pregnancy test. And in that you'll be detecting the level of beta hCG. The pregnancy kit which designs to rule out the beta hCG in the urine sample. So pregnant woman urine sample contain the beta hCG, which shows the pregnancy is positive. So you can use the urine as well as blood for the estimation of the beta hCG. Some receptor, as I have told before, which is act as a tumor markers, like estrogen receptors, which is done for the breast cancer, but is also increase in the some of the condition, some of the other cancer, which is hormone dependent. Okay, and you can use the tissue. You can use the tissue for the detection of estrogen receptors. Not the blood or the urine sample, you have to use the tissue sample for the to know the level of estrogen receptors, which is used in the case of the breast cancers and used for the diagnosis, guide the treatment, prognosis of the diseases. Another receptors, progesterone receptor, that is also done for the breast cancer, and this is also increased in the condition which is some of the other cancer, which is hormone dependent. And here also you have to use the tissue sample for the to know the level of progesterone receptors and used for the breast cancer. Monoclonal immunoglobulins. The sample can be used as the urine or blood samples. They use to diagnose, monitor, determine the recurrence, and it is for the cancer that is a multiple myeloma. As I told, it is a cancer of plasma cells. The cancer of plasma cell is known as the multiple myeloma. In the starting in the history, as I have told, Benzon's protein, which is present in the urine sample, that is used for the diagnosis of the multiple myeloma. Waldenstrom's macroglobulinemia. So in these conditions also you can use the monoclonal immunoglobulins for the diagnosis. And in these conditions the level of WBC, white blood cell, is increased. Okay, white blood cell is increased in this cancer. And the productions of the immunoglobulins or antibodies usually detected by the protein electrophoresis. So you can use the electrophoresis, and that electrophoresis is known as protein electrophoresis, that is used for the detection of immunoglobulins or antibody, which is detected by the electrophoresis. HCR2, human epidermal growth factor receptors. Okay, human epidermal growth factor receptor 2, which is used as a tumor marker for the breast cancer. And oncogene that is present in the multiple copies, that is a 20 to 30% of invasive breast cancers. Okay, so oncogene, as I told in the last class, this is the gene which is responsible for the development of cancer. So in this, the receptor, if it is a receptor, you are using the tissue as the sample, and this is also for the diagnosis, prognosis, and guiding the treatment of the breast cancers. So you can use the human epidermal growth factor receptor 2 for diagnosis, prognosis, and guiding the treatment of the breast cancer. So here you can see some of the cancer with the tumor markers which is used. Metastasis of the bone, CA you can use for the uterus, CA, C125, okay, which is generally doing in the practice. For liver and by CA, ARP, CA 19.9, which is in the common use. Okay, so these are the few tumor markers which has been used. So not only in the one diseases, one cancer, this tumor markers increase in the many different type of the cancers. Okay. So you can see CA, breast cancer, lung cancers, colorectal cancers, C125 ovarian cancers, CA 15.3 for the breast cancer, AFB, germ cell tumors, liver cancer, PSA specific for the prostate cancers. Okay, so these are the few common tumor markers which is increased in the different cancers, which is used in the common practice for the diagnosis, and later on for the treatment also they have used these tumor markers. So what is the limitation of these tumor markers? So there is a more than 50 or 100 tumor markers has been identified, but what are the limitations? Why it is not the specific? It is increasing the different age. Why? So what are the limitations for all these tumor markers? So a small amount of these markers is present in the blood of everyone. Almost everyone having the small amount of these markers in the blood. Okay. So you cannot say if it is detected that person is suffering from the cancer. That is one limitation. Second one, you can see to get the higher than the normal, only the large amount of cancer is present. The level of these tumor markers will increase when there is or the cancer is in the later stage, not in the initial stage. If the growth of that cancer is more, then only the level will be very high. That is one limitation. If it is a tumor marker, that means it should detect the early development of the cancer. If some person is just starting the cancer, that level should be increased. But that is a limitation of tumor marker. When this marker will be high only when the cancer is the later stage. If the mass which is developed inside the cancer patient is more, than only the level of this tumor marker will be high. That is one limitation. So some people with the cancer never have the high level of these markers. So this is also exception. Person is suffering from the cancer, but the markers which you have used, it may show the normal. That is a limitation of the tumor marker. You can see here the another limitation of the tumor marker. Even when the level of these markers are high, it does not always mean that the cancer is present, because it is also increased in some other conditions. Like as I told before, even the hepatitis, pregnancy, some of this tumor marker is increased. So that does not mean that the person is having the cancers. One example you can see here, C125 can be higher in the woman with the gynecological conditions. What you have studied, it is increased in the case of ovarian cancer, but it is also increased in some other gynecological conditions other than the ovarian cancer. So this is the limitations. It is not only increase in the case of ovarian cancers. It is also increase in some other gynecological conditions, which is not the ovarian cancer. So that is the limitation. So these are the few limitations as I have told. So what are the things you have to remember from this class? So no ideal tumor marker is known so far. So all the tumor markers have some of the limitations, advantage, disadvantage. So that's why no ideal tumor marker has been developed till the date. Okay. So what you have to do? To being a physician, tomorrow you are going to be a doctor. The patient will come to you. But as I told, the tumor marker is not ideal. There is no single tumor marker which will be ideal. Okay, in this condition only it will be increased. So what you have to do? So best thing you have to do is give some time to the patient, talk with them, and take the good history of that patient. You can ask regarding the patient, what happened to you? Ask all the things. Ask the family history. Not only the history of that patient, family history. Physical examinations. What nowadays they will do? Within the 2 minutes, they will send the patient. They will ask what they want. Having fever, having cough, this and that. Give the time to the patient and take the history and do the proper physical examination. Perform the physical examination properly. At least you have to give the half an hour for one patient minimum to take a good history and take the proper physical examinations. And we don't have any other options for these tumor markers. What you can do is don't use only one tumor marker. Use the more than one tumor marker for the diagnosis. Take the good history, physical examinations, and use more than one tumor marker. Don't rely on the one tumor markers. Use more than one. And also you can use the other investigation for the confirmation, histopathological. If the patient having developed the growth, then histopathological examination can be done. Take that tissue and see the morphology of the cell. Depending on the site where it is present, just a small bit of sample is collected, tissue is collected and sent for the histopathological examinations. If it is a cancerous, you will get the more amount of the cells. Abnormal cell will be present. So that will give the confirmed diagnosis rather than this tumor marker. But this will take time. Histopathological examination will take time. That's why you can rely on these three, which is in your hand, you can say, which can get the very faster. History, it's in your hand. Physical examination is in your hand. And these tumor markers, you can get report faster than these examinations, than the histopathological results. It will take around 7 days. Okay, it will take around 7 days. If you do very fast also, it will take the 3 to 4 days. So till that, what will do? So you can use the more than one tumor markers, which will help in the diagnosis. Confirmation you can do from all this: histopathological, ultrasonography, or rectal examinations. So this will help in the confirmation, but you can use the more than one tumor marker for the diagnosis. Take the good history of the patients, physical examinations. For all this, you have to give the time to the patient. Give the time. Tell them to explain what happened to them, why they have visited to you, what brought him to hospital. Ask them. Give the time. So you will explain each and everything if you give the time, and that will help in the around more than 50% diagnosis can be done by the history, physical examination. More than 50%. Only few can be supported by these tumor markers, and for more confirmation, you can go for the histopathological examinations for the cancer. So you have any doubt? So this is the end of the tumor markers. We have discussed only the basic and the tumor marker which is done in our setup. So do you have any doubt? This is all about the tumor markers, and yesterday we have talked about the cancer. Cancer, what is the cancer, what is the different type of cancer, the etiology of cancer, and today we have discussed the tumor markers, which is helping the diagnosis of the cancer. So do you have any doubt? If you know that, you can